Okay, so I'm going to talk. I spoke about this during your last conference as well, but we didn't have much cases at that time. I've done 50 cases already till now on CM guided biopsy. So I'm going to talk about my HKL experience. I will rush through the first few slices. I know everybody is hungry, okay, because you all have already heard most of it before. So coming to HKL breast imaging, we have two DBT systems, two tomosynthesis systems. We have breast MRI, two 1.5 Teslas, and we borrow the 3 Tesla from HTA. So among these two 1.5 Teslas, only one of them has a breast coil. So I cannot emphasize this enough. If you find out that your hospital is going to get an MRI machine, please make sure the head of radiology puts the breast coil into the tender, because a breast coil has to be purchased. And for some reason, it's not purchased by default. And it's always, they have to actually ask the radiologist, do you need this? Yes, we do. You do need it, and you must have the breast coil. And I've told my colleagues that if they ever send MRIs to any hospitals, it has to come by default with the breast coil, because our patients are getting younger, okay? So contrast enhanced mammography, we've done about 1,000 cases so far. And contrast enhanced mammography biopsy, 50 cases already. We're doing a research on this, and we've also got now artificial intelligence in mammogram. So coming to image-guided interventions, all the biopsies that we perform, most of them are done under ultrasound guidance, because most of the lesions can be seen under ultrasound guidance. But the calcifications and asymmetric densities, we have to do it under stereotactic biopsy. And Ms. Suniza has already presented on that and said how important it is for us to start doing vacuum-assisted biopsies. The entire world has gone towards vacuum-assisted biopsies. We're the only ones still, we are the few countries still doing core needle biopsies for stereotactic. Why? Because the needles are very expensive, and it is very difficult for KKM to purchase them. So now we've got tomo-guided biopsies, the calcifications, asymmetric densities, and an added value for architectural distortions, which are only seen on tomo. So this is early cancers that are seen on tomo that we can now biopsy with tomo guidance. MR guided biopsy must be done because there are cancers that are seen only in the biological phase, which are not seen at all on tomo, DBT, and also ultrasound. All right. So how do we biopsy these lesions? We must do MR guided biopsy. Unfortunately, there are only 3 hospitals: Slayang, IKN, and Putrajaya, which has the capability to perform MR guided biopsy. Why? Because you need MR friendly equipment. Okay, and MR friendly equipment is expensive. Even the needle has to be MR friendly. We can't use the regular needles that we use for stereotactic biopsy. It has to be an MR friendly needle. None of these hospitals are able to do this because we don't have the budget for it. All right. So we do not have any hospital in KKM at the moment that's capable of doing functional biopsy. And PPUM was doing it, but they also have a shortage of needles at the moment. So at the moment, nobody, and all the biopsies for lesions only seen on functional imaging are coming down to us in HKL. Why? Because we managed to get the first CM guided biopsy system in the country. So we're doing a research on this to see the feasibility of it. And it has been really good for all the lesions that are seen only on functional imaging. So we are now able to biopsy these lesions based on CM guidance. So 31 to 30, this is a study done by my colleagues in Italy, and 31 to 55% of CM lesions seen on contrasted mammography were seen on ultrasound. 62% were seen on second look DBT, because we have the DBT, the mammogram right next to the contrasted mammography. That's the beauty of contrasted mammography. And 76% were seen on contrasted mammography and ultrasound together correlating. Okay, what about the 24% that's not seen on any of these modalities? How are we going to biopsy those? So we used to give them 6-month follow-ups, all right? But now we have CM-guided biopsy. Introduced in 2019, FDA approval in 2020, and the first case was reported in 2022. Alcantara described the technical feasibility in 64 patients in 2022. So very, very new modality. So what is the indication? All the lesions that we see only on functional imaging, which are occult on mammogram, on DBT or 2D mammogram, and also on ultrasound. So the number of studies that have been done are so far very few, only 6 studies done so far. The first study was just to show the first case that they did. Alcantara did the study on 64 patients. This was the largest number of patients, and most of them concluded that it was feasible. the procedure time was 15 to 18 minutes compared to 60 minutes of an MRI, and the success rate was 95 to 100%. So all these studies showed that it's a very feasible modality. So how do we perform it? Basically, we give contrast to the patient, see the uptake of contrast in the breast, and we target it using stereotactic guidance, just like how we do a stereotactic biopsy. Planning is very important because if this lesion is not seen, because many times we have not seen the lesion when we are doing the biopsy. We see it on the previous CM, but during biopsy, suddenly it disappears. So we have to plan it so that we can see tissue landmarks on the 2D or the tomo to still proceed with the biopsy, even if we don't see it on the contrasted procedure. So patient preparation, just like a CT scan, the patient needs to be prepared for contrasted study, and the patient must have a previous CM to see where the location of the lesion was. Biopsy procedure, this is a very nice chart by Alcantara, where so at 0 minutes, we give the contrast. We wait 2 minutes for the contrast to flow adequately into the breast. And then we start only then, because we are compressing the breast, right? We don't want to compress immediately and not have contrast in the breast. We have to wait 2 minutes, then we compress the breast. The scout images are usually for us to identify that our biopsy opening is at the correct location. The stereotactic plus minus 15 done after that is for us to target the lesion, and then the targeting coordinates are sent to the machine. The machine will move to exactly where we need to biopsy. Then we clean the patient, anesthetize, the web needle is inserted. So then again, we do a pre-fire 15 plus and minus 15 degrees to make sure that post-anesthesia, the needle is still going towards the lesion, okay? And then we do the sampling and the marker is placed to ensure that we were in the correct location. So this is an example of one of our patients, injected contrast. 2 minutes later, we position and compress. This was the scout image. The lesion is there, plus minus 15 for targeting, and the coordinates are sent to the machine. Then we start with our cleaning and anesthesia, web needle insertion. We are going towards the lesion, and subsequently, we drop the marker in place. So this is the marker. So specimen sizes. So all this while we are doing core needle biopsies. This is a size of a core needle biopsy. It's about 1.8 mm wide. The larger the gauge, the smaller the biopsy size, all right? So 1.8. Now that with these vacuum-assisted biopsies, we're getting the specimen to be about 2.5 mm wide. So we're getting much more of the lesion in some of that. And like what was presented, the entire tomato was sucked into the vacuum-assisted biopsy needle. So this is the direction we should be going. But like I said, it is costly. So this is one patient. We had to take 13 specimens on core needle to get all her calcifications in 13. And this is the maximum we take is up to 6. But we are doing 12. We're taking from 12 different sites on a vacuum-assisted biopsy. The needle actually, the needle actually moves. The aperture actually moves in all directions, and we're getting 12 specimens. And this is what the specimens look like on the vacuum-assisted biopsy. So I'm going to talk about the cases now. So 65-year-old presented with right breast pain for 2 months. She had family history of breast cancer, her sister. Mammogram showed an asymmetric density only on the CC view. CM showed a right upper outer quadrant enhancement with no sonographic correlate. So this was her asymmetric density. This was on her tomo. It didn't give us any added information. And this was her enhancement. So we proceeded to do a biopsy. This is how we would measure from the nipple so that our radiographers will get the exact accurate measurement as to where the biopsy opening has to be. This is a bit tedious because if they're not in the correct location, we can't biopsy the area and we won't be able to see the enhancement. So they actually measure from the nipple and they will mark where the measurement is. So this is done very, very delicately, and then the biopsy is marked. The area of biopsy is marked. All right, so 5 minutes left. So this is us targeting the lesion, plus minus 15. And this was the marker placed, which shows that it's in the correct location. This was a sclerosing adenosis and intraductal papilloma. Coming to case 2, 51-year-old female had previous history of left invasive lobular carcinoma, post-white local excision and sentinel node biopsy on routine follow-up. She had very dense breast. So what we've done now in HKL is all the patients with cancer and have Piret's D density, their follow-up will be done with a CEDM. And this is one of the cases that we did a CEDM follow-up. There were 2 enhancing lesions seen. Even when we look back retrospectively, we couldn't see these lesions. And these lesions were not well seen in the MLO because they're behind her scar. And so there was no sonographic correlate. We proceeded to do the scout plus minus 15. We did her biopsy, and this patient had her marker was placed, which shows that it's in the correct location. It was an invasive lobular carcinoma grade 2. Okay, only because she had dense breast, and when we look back retrospectively, we still can't see the lesion. Okay, so 61-year-old female, history of right breast cancer, post-right white local excision, and sentinel node biopsy in 2019, completed chemotherapy. Routine surveillance, we saw a left breast asymmetric density. Can you all appreciate this? Yeah. So we were investigating this asymmetric density. We said, her breast is quite dense. Let's put her up for a contrasted. The asymmetric density did not enhance, but what we did see was another lesion enhancing at the upper outer quadrant. And this, we look back retrospectively, we still can't see the lesion. And the lesion was showing more of a progressive enhancement. However, we did a CEM web for this patient. It was a focal low-grade apocrine ductal carcinoma in situ in a background of marked sclerosing adenosis. The hook wire was done with wide local excision. It was lobular carcinoma in situ, intermediate grade DCIS with marked sclerosing adenosis. The asymmetric density was just a red herring to take us to what we actually needed to see in her breast. So all Barrett's D density now we follow up with a contrasted mammography every year. So coming to case 4, a 50-year-old woman with history of right breast invasive lobular carcinoma in 2017. She had a nipple-sparing mastectomy and tram flap on the right side, presented with skin nodules on her neck and trunk. She went to a private hospital. They took a biopsy of the skin nodules, which turned out to be a metastatic lobular carcinoma. A mammogram and ultrasound was done there. There was nothing. They could not find anything. So she was referred to us and we performed the contrasted. Can anyone see anything here? So we saw this asymmetry. So this is a reconstructed breast. We saw this asymmetry, but we couldn't see it here on the CC because it's very posteriorly located. Not much added information given on the tomo. And this was the contrasted mammography. We can see an enhancing lesion at the left upper outer quadrant. So we targeted this lesion and we did a CEM web for her. It turned out to be, this was her targeting and her CEM web procedure. And the marker was placed in the correct location. It was an invasive lobular carcinoma. So if we didn't have this modality, or if you don't do MRI and MR-guided biopsy, how are we going to target this lesion? So at least now we have something that's so feasible that's attached to our mammo units, all right? So coming to the last case, 34-year-old presenter with bloody left nipple discharge was referred to us from a private hospital because she couldn't afford the further cost there to biopsy her left intraductal, 12 o'clock intraductal lesion. So we biopsied it twice. We saw a lot of intraductal lesions, biopsied it, kept coming back as B3 lesions, intraductal papillomas. We performed a contrasted mammogram and the CEM showed, so not much information here other than possibly an asymmetric density here in the retroareola. A bit of an architectural distortion on the CC, but we couldn't correlate it on the MLO because the breast was quite dense. And this was the extent of a lesion. All this was disease. So radiologically, all this is disease process. And our repeated biopsies were coming back as B3 lesions. Now, how are we going to plan the op for this patient? We're getting B3 lesions, but radiologically, we're seeing a very suspicious area of enhancement. So we proceeded to do a CEM web for her. This is something like the case that was earlier presented. Repeated biopsies coming back as benign lesions, but then we didn't waste much time. We proceeded with the CEM web for her. We focused on this area of enhancement. This was her ultrasound guided biopsy. This was her post-CEM guided biopsy. We focused on this area. It was a microinvasive CA in a background of indeterminate grade DCIS. So it has really helped us in our setup. It has really helped us in our workflow. It is much faster. It is very fast. It is cost effective, and it is done within 15 minutes. All the cases that I've done, maximum was 16 minutes compared to 1 hour of an MR guided biopsy, and taking up 1 hour of your MR machine HKL, it's impossible. Even to get breast MRIs in, is like we only get 4 slots a month. So I don't think they'll ever give us the machine for 1 hour to do a biopsy. So it's a very feasible alternative to MR-guided biopsy. And now that we are doing more and more screening with CM for dense breast, this is definitely something that's going to be needed. Thank you. Thank you very much.
Thank you, IMX and Dr. Maninderpal on the talk on CM. So the next point would be lunch break.